everyone. Our next talk will be from one of the ED physicians, Dr. Rishi Malik, who's very kindly giving this talk on his lunch break while he's working, going through some in-flight medicine cases.
All right, so my talk is, I actually cover both, it's called Extremes of Altitude, both kind of in-flight medicine and also a little bit about dive medicine as well. So let's get started. All right, so you're on your vacation block. You're looking forward to lying on a beach in the south of France and forget about medicine for 2 weeks. But first, you have to get there. So you get to the airport and you board your flight. You're on your flight. It's about 5 hours into your flight, and you hear overhead, "Any medical professionals, please identify themselves to the nearest flight attendant." You get up, you identify yourself as a physician, and the flight attendant takes you to the front of the plane, and you find someone sitting there in respiratory distress. So now what? So we're going to go over some in-flight emergencies. So medical emergencies happen in approximately 1 in 600 flights. Any flights that are over 3 hours long are much more likely to have a medical emergency. Generally, the longer the flight, the higher the likelihood of an emergency. And it's not just the increased time in the air that is the reason for this, but also other physiological factors that relate to being in an airplane, essentially. And we'll go over those. So let's start off with flight physiology. So it's 1 second. All right, so you have kind of 3 main things. The first thing is the cruising altitude. Most flights, or commercial flights, generally have a cruising altitude of 30 to 40,000 feet. The cabin is usually pressurized to 5,000 to 8,000 feet. And with this, you have to remember Boyle's law. And for those that don't remember their, I guess, high school physics too well, essentially pressure 1 times volume 1 equals pressure 2 times volume 2. And so at approximately 8,000 feet, compared to sea level, gas expands by 30%. And the greatest effect of this is on enclosed spaces in the body. One of the big areas is the sinuses. That's, as I'm sure you've all experienced on a flight, you have that kind of, your ears pop. The next greatest effect is on, or the other areas that are affected as well are other gas containing areas, such as the GI tract and the lungs. And the next kind of factor that comes into a lot of emergencies on flights is dehydration. And this is due to the level of humidity in the air and filtered or recycled air that is kind of put in the cabin of a plane. Another thing in the same kind of realm of dehydration, or that contributes to it, is people tend to drink less water when they're on a flight, especially in this day and age where you can't take bottles past security. Flight attendants don't really come around as frequently with refreshments. And so the next thing with flight physiology is there's a whole expansion of gas, which is interesting. But the reason why we care about it is with this lower pressure, there's a decreased partial pressure of arterial oxygen. And for a healthy person, it's negligible. It doesn't really have any effect. But with someone with chronic lung disease, it can have quite a significant effect because they're much lower on this curve. So you'd have like the average person would kind of be sitting where A is on this graph on the right. And then the average chronic COPD patient may be sitting closer to B. And there was actually a study that showed as many as 18% of people with COPD have some sort of mild respiratory distress on a flight. And another thing to kind of keep in mind is with this increasing volume of gas at this decreased pressure, anyone who's had recent GI tract surgery, a pneumo, eye surgery, or intracranial surgery have risks of just complications from being at this altitude. And they generally tell these individuals to wait 2 to 3 weeks before flying. And so what kind of emergencies do you see kind of on a flight? So the biggest one is syncope near syncope, counts for 30%. Next, you have GI distress at 15, respiratory distress at 10%, cardiovascular at 7, and so on. Luckily, cardiac arrests are only 0.2% of these emergencies. And the other part that's good is OB obstetric related emergencies are at 1%. And so when you kind of run into the situation that you respond to an emergency on a flight, what can you expect to find on board in this kit? So in the US, at least, the FAA requires any aircraft flying within US airspace that has more than 30 passengers to have essentially a kit with these above listed things. And with this, at minimum, you'll also have a basic first aid kit, which has like gauze, bandages, and also some oxygen. I read that there are some places or some flights that apparently have EKG capabilities. I couldn't find any example of an airline that has it, but there may be some special situations where you may have that capability. And again, I'm not sure how this EKG machine would look like or how it would function, but apparently in certain special cases, they may be available. And there are some flights carry more than what's listed here as well. One common thing that's carried by a lot of flights now is Naloxone, just for things like opiate overdoses. And let's just briefly go through this kit. So essentially, with medications, you have epinephrine for your allergic reactions, an antihistamine that's injectable, dextrose, and so just anyone that's having a kind of a diabetic emergency, nitro for things like angina, and then you have some sort of analgesic, anticonvulsive, an antiemetic, bronchodilator, some atropine if you had someone with like bradycardia, steroid, diuretic, medications for postpartum bleeding, just normal saline, some aspirin, beta blockers, and then as far as equipment goes, stethoscope for obvious reasons, blood pressure cuff again, obvious reasons. Airways, they usually have oropharyngeal airways. So just if you, for whatever reason, had to ventilate someone, you could easily use that on just about anyone. Syringes, needles, IV catheters, everything to get an IV started and kind of give some of those injectable medications or saline. Gloves, sharps, a urinary catheter for individuals that go into urinary retention, which can be very, very uncomfortable. And then otherwise, these are pretty basic things. The rest of these, umbilical cord clamp in the off or quite rare chance that you have to actually deliver a baby on a flight, which sounds terrible. I would hate to be in that situation. And then BLS cards, bag valve mask, and a list that just essentially mentions everything that they have on board that you could use. So some airlines actually have special programs that doctors can be a part of, and they have certain benefits. So here we have the Lufthansa, Australian Airlines, and Swiss kind of program where you get some reward miles, you get some special luggage tag, a promotion code for like 50 euros off, and certain other things. And you can attend this course, which you can actually get CME points for. But in most cases, most airlines don't have a program like this. So what do you do in an event of an emergency on board? First thing you want to do is identify yourself. You'll likely hear a call overhead asking for medical personnel. And when you identify yourself, they'll ask you what your profession is, and then they'll ask you your specialty. They may ask for identification, which is kind of weird considering I don't think most of us walk around with our hospital identification or like our degree in our back pocket, but it's rare, but it does apparently happen. And Otherwise, if there are multiple medical professionals on board, they're going to choose who they kind of decide is most qualified. So for example, if it was an obstetric emergency and there was an OB on board, that they would be the most qualified. And sometimes they'll have multiple people come up depending on the emergency, just so you can have multiple hands. And otherwise, what the next step is, after you identify yourself, is to ask to see the passenger. One thing to keep in mind, that you're there to assist, not really take over. At the end of the day, the flight crew for everything has, in a way, final say. They may initially give you a basic first aid kit. You may have to ask for the full medical first aid kit, which has that list of things listed and plus more usually. And when you see the patient, treat it like any other undifferentiated patient. So you do go through your basic H&P, take vital signs. If you had, like, for example, a nurse that happened to be on board as well, that'd be quite useful because they could do some of the tasks such as taking vital signs, starting a line, and so on. And once you have an idea of what's going on, the first thing I'd recommend is opening that medical kit and looking at the card that lists everything that you have at your disposal, just so you can figure out what you can actually do in the situation. Most airlines, or pretty much all of them, have contracts with ground medical personnel who they call in emergencies like this. And in a situation like this, you will be able to talk to these individuals, and they're well versed in in-flight emergencies and in-flight medicine. And they essentially will give you recommendations on what to do. And then I really enjoy this picture, this person vomiting, all her meds there, and then a bottle of what looks like to be Jack Daniels. Seems like a good combination. So what do you do if this person seems sick? You have your basic meds. If it's cardiac arrest, you'll have an AED, a BVM, you'll have epi, though not really the right dose. And you'll have the ability to start an IV. If they seem unstable in kind of some way, such as they have chest pain, seem diaphoretic, you may be thinking they have an MI, treat it like any other emergency. Get a line started, put on the pads, but be very aware of your limitations. For example, in a situation like that, like I said, there's apparently the rare case where you may be able to get an EKG, but 99% of the time you will not. So if you're thinking they have a MI, you might not want to jump to nitro, for example, because there's no way to know if it's an inferior MI. And if you think the patient's unstable or needs a urgent higher level of care, you can ask the pilot to divert the flight to the nearest airpoint. This decision is usually made in conjunction with the ground medical staff. And at the end of the day, the pilot has the final say. They have to weigh other issues such as safety of diverting and whatnot. And just fun fact, the usual quoted cost of diversion is anywhere from $25,000 to $750,000. So medical legal, first question, am I obligated to help? Other than the whole Hippocratic Oath thing, and the US, Canada, the UK, you're not legally obligated to help unless you have an existing doctor-patient relationship. I guess if you were someone's PMD and you happen to be on the same flight. And other countries, such as in the EU or Australia, you may be obligated, but it's not entirely clear. And the other thing that complicates all of this is what country has jurisdiction over the flight. So if you're over international airspace, it's essentially so that would be over the middle of one of the large oceans. It's the country the plane is registered in. If you're over sovereign airspace, it's the country's airspace you're over. And again, this is very hard to decipher when you're sitting at like 30, 40,000 feet in the air and there's an emergency happening on your flight. One thing to be aware of and take note of is never pronounce someone dead on a flight. It's a nightmare in terms of where they were pronounced. If you're licensed to pronounce someone in that jurisdiction, and if you just think of it just simply, think of how much of a struggle, at least in the ED, we have to fill out a death certificate and get e-vitals to work. Now, imagine trying to do that while you're flying over Turkmenistan or some other country where, again, no idea what the laws are, probably not licensed. So yeah, it's just recommended that never pronounce someone dead. Oh, and if anyone has any questions that I go, feel free to kind of interrupt me. I can't see the chat in case there's anything there. And now moving on with some more kind of medical legal stuff. If you fall into the U.S. jurisdiction and provide first aid on a flight, you're protected against legal action to an extent. And that extent is gross negligence or willful misconduct. Essentially, you have to do something terribly wrong to have a civil suit brought against you. And the other thing to be wary of is intoxication falls under this category as well. So if you were throwing back gin and tonics for the first few hours of your flight, I would recommend just not getting involved. The other thing to consider is compensation. If you seek compensation for your role in an emergency, you jeopardize or may jeopardize his protection. And it's unclear if an airline offering you free upgrades or travel vouchers would be considered seeking compensation. But to date, there is no case law related to this sort of thing. And if you're outside the US jurisdiction, it gets quite complicated because it's a combination of laws in various countries and also a couple kind of international conventions. There's the Montreal Convention, the Warsaw Convention, the Tokyo Convention that all come into play. And generally just act in good faith and don't be grossly negligent and you will be fine. Now, moving on to scuba diving emergencies. So kind of going to the other end of the spectrum, from being high up in the air to being deep in the water. So just basic background on scuba diving. There are two main diving organizations kind of in the world. There's PADI and the NAUI. They usually require a 2 to 3 day course. It involves classroom work, some in-water training, and that's pretty much all it takes to get certified to dive. Basic tank that divers use are not 100% oxygen. They're 21% oxygen, 79% nitrogen, and these fractions can change for more advanced divers. The recreational dive limit is set to 40 meters or 131 feet. And for every 10 meters you go underwater, the pressure increases by approximately 1 atmosphere or 100 kilopascals. Now, diving emergencies can be broken down or grouped into 4 main categories. You have descent, ascent, emergencies at depth, and marine or water injury. We're going to cover the first 3 as the last one is more related to just being in water or the ocean, less with the act of diving. So starting off with descent, these are generally the more benign injuries. So let's jump back to Boyle's law. In this situation, instead of the volume expanding due to decreased pressure, like on a plane, we have the volume of gas decrease due to increased pressure. And as I mentioned before, every 10 meters underwater is 1 atmosphere or 100 kilopascals of pressure. And because of this, the injuries related to descent all have to do with this increased pressure. When you're going down, divers are taught to equalize the pressure in their ears and sinuses. This can be done by kind of plugging your nose and blowing. And when you run into a problem and you equalize the pressure in the water and your sinuses, but there's a problem when there's a disequilibrium there. And sometimes issues like congestion or inexperience can lead to these errors in equalizing. And usually the main things that happen are you have your tympanic membrane rupture, you can get tooth pain, periorbital emphysema, epistaxis, and the pressure imbalance can also cause compression or ischemic neuropraxia of the infraorbital branch of the 5th nerve, and it can cause tingling and numbness of the cheek or upper lip. The next injury of descent that can occur is mask squeeze. And now, essentially what mask squeeze is, as you're going down, the pressure in the area between your goggles and your eyes, that is less than the pressure of the outside water. So the volume of air in between the goggles and your eyes decreases, and this can create a vacuum. And so a small amount of mask squeeze is actually useful for divers. It helps create a good seal between their goggles and the skin and stops water from kind of getting into the goggles. Though if you don't equalize as you go down, what happens is this kind of vacuum effect gets greater and greater, and it can lead to periorbital trauma. So you can have periorbital bruising. This kind of pictures a severe case of mask squeeze. periorbital bruisings, conjunctival hemorrhage, and in the most severe cases, you can get a retrobulbar hemorrhage. And for these patients, if you ever happen to see one after this happened, it's important to get ocular pressures, mostly to kind of rule out that retrobulbar hemorrhage. And so, like I mentioned, descent-related injuries are generally not as bad as ascent or depth-related injuries. So when it comes to depth, there's three big things: nitrogen narcosis, oxygen toxicity, and decompression sickness. So nitrogen narcosis begins to occur at depths of 21 to 31 meters, and at these depths, the symptoms are usually lightheadedness, loss of fine sensory discrimination, giddiness, and euphoria. It's a little like being drunk. And usually that these depths do fall under recreational diving depths. It's depths deeper than recreational diving where nitrogen narcosis can get really bad, and like a very kind of intoxicated type feeling, impaired judgment can occur. And for this reason, technical divers have other mixtures of air that they can use, such as heliox or enriched air nitrogen, which have lower levels of nitrogen in them. And the reason why this occurs is kind of unknown, but they think it may have a similar kind of effect as when the anesthetic nitrous oxide is used. And the treatment for this is pretty simple. You just ascend. Next, we have oxygen toxicity. This, again, is rare for recreational divers, as what increases your risk of this is the increased partial pressure of oxygen in the air you're breathing. So this actually happens in more kind of advanced divers that end up using enriched air nitrox mixtures, and the increased pressure of being in deeper dives for prolonged bottom times. And the two main manifestations of this are pulmonary oxygen toxicity, which presents as lung damage, and severe cases can require intubation and kind of PEEP to have that adequate oxygenation of the lungs. But again, in your general recreational diver, this would be rare. Neurological manifestations are the second type, which can come as apprehension, air hunger, or focal muscle twitching and seizures. And the last kind of emergency or big one of kind of at depth is, or with Ascent, is decompression sickness, or as some of you may have heard it called before, the bends. It's caused by nitrogen bubbling out in the tissue and vessels. It's quite rare. It's thought to happen less than 0.01% of divers. And the basic mechanism is at depth, the nitrogen dissolves into liquid in the body, and the amount of dissolved nitrogen is a function of the composition of the nitrogen of the inhaled gas and the depth you're at and the time spent at that depth. So we can go over some of the symptoms here. So you can have like basic things, which are just like muscle pain and kind of pain related symptoms. Then you can have kind of some of the more severe things, such as your neurologic symptoms that involve kind of hyper or paresthesias. It can be paralysis and certain things like that, and then brain kind of issues where it's confusion, headaches, so on. You have fatigue, and so on. So the big question is, how do you diagnose this? Most patients display symptoms within an hour of resurfacing. Some may be delayed as much as 3 hours. And the mainstay of the diagnosis is a good history and physical. And with that, it comes finding out details about their dive. How many dives did they have? How deep did they dive? What gas did they use? Did they follow the appropriate decompression stops and protocols? And with these patients, what you want to get are basic labs. If they have any neurologic signs, consider a head CT or MRI, but these shouldn't hold up the treatment. And the mainstay of treatment is hyperbarics. Though most of these air injuries unfortunately happen in areas where there is not immediate hyperbarics located. And in this situation, while transporting the patient, you can just put them on a non-rebreather, which can kind of help resolution of those inert gas bubbles. Isotonic fluids can help as well, 1 to 2 milliliters per kilogram per hour. And you can find the nearest hyperbaric chamber by calling the Divers Alert Network. And most dive companies that recreational divers dive with know where the closest one is. Another thing to be aware of about these chambers is they can only take a few people at a time. So say you could possibly call a nearby one just to find out that it's currently in use and cannot be used by another individual. And to complicate matters, the closest one may just be a flight away. So you would also have to find a plane that can be pressurized to sea level or fly at a very low altitude. Now we're going to go to Ascent. There are 3 big things here. There's Alternobaric Vertigo, facial Baroporisis, and pulmonary Barotrauma, and arterial gas embolism. So Alternobaric Vertigo, it's caused by unequal pressures in the middle air during the ascent. One ear may equalize, the other one might not, can cause dizziness and vomiting. You can resolve it by trying to equalize the other ear, as mentioned before. We're kind of plugging your nose and blowing into it. It usually self-resolves in hours, and very rare cases may last days. And it's dangerous because if you experience this sensation while you're ascending, but still have safety stops to make as you ascend, some individuals may just rapidly ascend and put them at risk of decompression sickness. Next, facial baroporisis. So the 7th cranial nerve runs through the middle ear, and parts of this nerve is subject to the pressure of the middle ear. So if during ascent the diver isn't able to equalize their middle ear, it can lead to increased pressure on parts of the ear, and this pressure, essentially what happens, if the pressure is greater than the capillary pressure of the nerve, it can lead to ischemia of that nerve. And it can be accompanied by symptoms of ear fullness because of this difference in pressure, and pain as resurfacing. On exam, you can actually see a bulging TM, and it can be confused with the neurologic manifestations of decompression sickness. So in decompression sickness, you should also always look in the ears to see if their TM is kind of bulging. Myringotomy is the treatment of choice if it's persistent. Eventually, the air should just resorb on its own and equalize, but if you wait too long with this, like the few days it may take to fully equalize, it can lead to ischemia of the nerve and permanent kind of paralysis or issues. Another interesting thing you can do with this, if someone has this, if you dive down to 10 meters, it'll usually cause the symptoms to resolve by increasing the pressure in the unaffected ear. And next we have pulmonary barotrauma and arterial gas embolism. So this generally happens during ascent if the diver holds their breath. Because of the decreased pressure as you ascend, the volume of gas increases and can lead to alveolar overdistension and rupture. This can also cause pneumomediastinum, pneumothorax, and a arterial ear or gas embolism. It's more common in decompression sickness, and it's one of the bigger causes of death and disability in divers. The arterial gas embolisms are caused by these rupture of the alveoli as that pressure in the volume in the lungs increases, and it can lead to bubbles in the pulmonary venous circulation. Then it goes to the left heart and is transmitted throughout the body. These emboli will shower the brain and cause widespread neurologic symptoms and damage, and they can also be lodged in the coronary arteries and cause arrhythmias. 4% of these individuals have an immediate arrest secondary to arrhythmia, and they also, like I mentioned, can present with neurosymptoms. You can also get other nerve damage just by these bubbles. They're essentially, again, like any other emboli. And the treatment for this is similar to decompression sickness, where it's hyperbarics and in the interim, a non-rebreather. Interestingly, you should always get a CK with these patients because the degree of elevation of the CK is correlated with the extent of their neurologic recovery. So just to quickly summarize everything, in-flight emergencies, should you help? Probably. Ethically, yes, you should definitely help. legally, depending on what airspace you are in, or where the the airplane is registered, you may be obligated to help. So just help, again, as long as you're not intoxicated, again, because of that grossly negligent portion of everything. And so far, or to date, there is no documented case law against a medical professional who volunteered aid on a plane. There's one example of a surgery resident being named in a suit, but it was quickly dropped once his residency hired a lawyer. And you have when it comes to the kit you have available to you on a flight, you have some basic meds, basic equipment to take vitals, start an IV, basic first aid things, oxygen. And again, remember that card is very important because it'll tell you exactly what's in the kit and what's at your disposal. And like I mentioned, practically all of these airlines have contracted medical personnel on the ground who help in these emergencies. And with these individuals, you have to remember at the end of the day, if they say this is what you should do or what to do, you should follow what they say. And at the end of the day, like I mentioned, you can only give your professional opinion when it comes to diversion. The final choice rests on the captain and the crew. And also just remember, for any reason, they can kind of decline your help. So just summarizing the scuba diving emergencies, a lot of severe diving emergencies can mimic a stroke. Will present with neurosymptoms, and the treatment for these are generally hyperbarics. Details matter in the situation. Do they have one dive, multiple dives? How deep? Did they take the appropriate rest stops? Did they use nitrox, heliox? Did they dive and immediately get on a plane? When did the symptoms start? While ascending or an hour later? If you ever find yourself in the situation of taking care of someone with a suspected dive emergency that requires hyperbarics, definitely call the Divers Alert Network. During business hours, they actually have a dive physician you can speak to, and they will kind of be able to also direct you to the nearest hyperbarics. And if you haven't been diving, I highly recommend it. Don't let my talk scare you. It's a lot of fun and generally safe as long as you follow the appropriate guidelines. And otherwise, here are my references. And that's